Um, let's see. So, prostate cancer. Here's a very controversial topic. And the urologist will hate me for this, but I have to let you know. So, we used to do what we call screening PSAs, right? Okay, so, you do a blood test, PSA, oh, the PSA is high, you do all sorts of things, you do prostate biopsy, oh, tumor. And they always get surgery, radiation, or something to address that. Well, it turns out it's not as simple as that. Because what they discovered was if you do surgery on every single case of prostate cancer you diagnose, that actually leads to a lot of needless surgeries. The problem when you do a radical prostatectomy is you become impotent, sometimes you become incontinent. There's a lot of morbidity associated with the procedure. Okay? Now, it turns out, and I can quote you the exact numbers, and if there's any urologists in here, I'd welcome a debate. Okay? If you look at, and this is from the NIH, National Institute of Health, what they did was, when they do autopsies, they look at the prostate to see if there is prostate cancer there. Now, I'm talking about men who died from other causes, not cancer. Heart attack, diabetic complication, vehicular accident, stroke, you name it. Nothing to do with cancer. And they got their autopsies, they looked at the prostate and see if there's cancer there. Do you know the incidence of a symptomatic prostate cancer among men who did not have, who died from other causes? Okay, I'll tell you. Among white men who died from causes other than, didn't even know they had prostate, didn't get a PSA, the incidence of asymptomatic prostate cancer in white men is 36%. 1/3 of men who died had prostate cancer who would not have bothered them at all. Okay? 36%. Gets even better among black men. The incidence of asymptomatic prostate cancer in black men who died from other causes is 51%. Okay, which brings to question, why the heck do we do PSAs? Because what's going to happen is, you will just find these prostate cancers, which basically will not do anything to these people. And you subject them to morbid surgery and radiation. So now we know that one way to determine that is by the thing called Gleason grade. Okay? So it's basically a grading system to see how aggressive the prostate cancer is. So the magic number to remember is 6. A Gleason grade of 6 and below is not an aggressive prostate cancer. Those people, and this is now the adopted guideline of ASCO. If the PSA, if the Gleason grade is 6 or below, you do not do surgery on these patients. However, with the caveat that you have to watch them carefully. So they have to get a PSA every 3 months, okay, and see if the PSA is going up or whatever. If it's doing, then they go surgery. If the PSA is doing this, you watch them. You do a PSA every 3 months, sorry, a prostate biopsy once a year. You have to do those 2 things, all right? Which also brings into question, how effective is a screening PSA? And the answer is it's not effective, which is now, why now in the US, we don't do screening PSAs anymore. We used to. We don't do that anymore. It's useless. Okay? All it does is cause anxiety to the patient or needless surgery or needless radiation. Which is why there's a big push in the US now to find a surrogate marker to take the place of PSAs. Okay? We don't know what that is yet. That's a hot topic of research right now. Whether it's bloodborne or whatever. But we don't do screening PSAs now. Okay? If this were a simple appendectomy, yeah, go ahead, I don't care. But men who undergo radiation therapy, they get enteritis, inflammation. Those who get radical prostatectomy, they cannot have sex anymore because they're impotent. How would you like that? When it would not have been necessary to begin with. Okay, so the story for the screening for prostate is still out there. The PSA's standard approach in the US, we don't do screening PSAs. If you do a biopsy and it's Gleason 6 or lower, you watch. 7 and higher, yeah, you do the surgery, radiation, whatever you want. Okay? So that's the big thing about prostate cancer. Now, you probably have heard about this thing called BRCA, BRCA. I didn't realize this, but I was like, ano kaya ibig sabihin ng BRCA? By whatever, yung pala ibig sabihin ng BR breast cancer. BR breast cancer. Yun lang pala ibig sabihin na. So, breast cancer, BRCA gene is also important because especially in triple negative patients. Okay? Because if you are BRCA positive, we also have pills to treat a BRCA positive breast cancer patient. We don't use it so much in the HER2 because the HER2 is a much more powerful prognosticator. We don't do it so much in ER/PR positive patients because we have good, less toxic drugs now, and I'll go back to that in a minute. So if you have this applies mostly to the triple negative variants because, like I said, we don't have anything to treat them with until Braxine and Tecentriq came out. So if you're BRCA negative, you're BRCA positive, we have what we call PARP inhibitor drugs, olaparib, all sorts of things. They're also pills, and they are effective for BRCA positive, triple negative. So that's where it has its application in triple negative metastatic. Okay, before I forget, let's go to the ER/PR positive breast cancer patients. Okay, so you get surgery, you do a PET scan, it's localized, right? How do you know what your risk of recurrence is? Okay?
How do you know?
Your risk of recurrence. In other words, you take out the tumor, you did a lumpectomy, mastectomy. What are you going to do next? How do you know that the tumor is gone, that it won't come back? Because as you know, a lot of times you do the lumpectomy, mastectomy, and years later the cancer is back. And the bad thing is it's in other places. Then you become incurable, right? So we do adjuvant therapy, right? So usually, in the past, if you're ER/PR positive and you're postmenopausal, then you get a pill called, anybody here? Arimidex, right, good. So they are what we call AI, aromatase inhibitor, because they inhibit this enzyme aromatase, okay? Now, remember this very carefully. If you are premenopausal, that drug will not work. Another common mistake people make. So, okay, ER/PR positive patients, right? They have the receptor there, so you're trying to block the female hormone from interacting with that receptor to prevent growth, okay? So, the original drug for this is a drug called tamoxifen. Very good. Tamoxifen is actually the very first targeted therapy in the history of medicine. Tamoxifen came out in the 70s. It's an anti-estrogen drug. Okay? So, the estrogen blocks the interaction between the receptor and the female hormone. Right there. That's how tamoxifen works. The AIs came out later. Okay? The problem is this. Why won't it work in premenopausal? Remember that enzyme aromatase? What exactly is that? Aromatase inhibitor. That's what Arimidex and letrozole and Femara are. Okay? Aromatase inhibitor. So like when women become menopause, before menopause, where is the main source of estrogen and progesterone in women? Something you have that I don't have. The ovaries, correct. 95% of the estrogen and progesterone come from the ovaries before menopause. When you become menopausal and you burn out your ovaries, where do you think the estrogen and the progesterone come from? Peripheral fat.
From where?
Fat. Fat. Okay? Kasi if you do an estrogen level on a post-menopause, you say, oh, ba't may estrogen pa to eh? Wala na tong ovaries. Because peripheral fat is converted into estrogen by the enzyme aromatase. Got it? Your fatty tissue aromatase estrogen. That is what's being blocked by letrozole and arimidex. That's why they're called AI, aromatase inhibitor. Which is why it will not work in premenopausal women, because the source of estrogen in premenopausal are the ovaries. Now, in menopausal women, the source are peripheral fatty tissues. If you give arimidex to a 45-year-old woman, you're stupid. It's not gonna work. Okay? Clear? Makes sense? All right. Now, so you get the biopsy, if you're positive, you do not have lymph nodes, or you have lymph nodes. In the past, we will automatically, okay, for patients who are stage 2 or lower, let me make it simpler. For patients who have localized disease, complete resection, no lymph nodes involved, you give them either tamoxifen if they're premenopausal, perimenopausal, or an AI if they're menopausal. Okay? In the past, they say 5 years. Now they're saying it should be 10 years. How do we know that it prevents a recurrence? Because the studies show that. These are the adjuvant studies that were done back in the 80s. NSABP, National Surgical Adjuvant Breast Project. Anyway. And then they looked at, so before we only had tamoxifens. Everybody would get tamoxifen, pre or post. Then when the AIs came out, they did a study comparing the AI to tamoxifen only in what type of women? Postmenopausal, right? So your study group are postmenopausal women with early stage cancer who are candidates for adjuvant therapy. Okay? One group got the standard, which was tamoxifen. The other group got the experimental drug, which was the AI. Okay? The AI won. We're only talking postmenopausal, you remember that, okay? So, postmenopausal women, early stage breast cancer, they get an AI for 5 years. Premenopausal, they get the tamoxifen. And this is where the confusion comes in, because when that study came out, some people did not think about where the AIs work, so they gave AI to everybody, including premenopausal women. Mali yun. Eh? Mali yun. And if your oncologist says, because I said so, tell them, alright. So that's what we used to do. And if they had lymph node involvement, meaning to say the cancer, they already tapped the lymph node involvement is the worst prognostic factor for risk of recurrence. Before, traditionally, and if you had lymph node involvement, you get chemotherapy, then you get the AI. That all changed with a test called Oncotype DX. Who has heard about Oncotype DX here? Okay, that is a very, very important test because that more accurately predicts a patient's risk of recurrence than the traditional tumor size lymph node involvement. Okay, what is Oncotype? So Oncotype, what they did is they looked at, it's a 21 gene panel. So they identified genes that are associated with breast cancer, good genes like ERPR, bad genes like HER2/neu. It's a 21 gene panel. And what they do is, when they do a biopsy, they actually look at the genomic profile of your tumor, your particular tumor. They compare that to the 21 gene assay. And they have a very complicated mathematical algorithm, and they come up with a so-called recurrence score, RS. Okay? And if your recurrence score is 25 or below, I don't care if you have lymph node involvement, you do not get chemotherapy. Okay? The 2018 ASCO convention, the most important paper presented was the Taylor RX study, which looks at oncotype. To me, it's a crime if you do not do that. Because in that study, if you look at patients who would have gotten chemotherapy because they had lymph nodes or big tumor size or whatever, this is completely independent of lymph node involvement or tumor size. And this is more precise. In that study, 30% of patients who got chemotherapy had a recurrence score of 25 or below. So 30% of women got needless chemotherapy. And that's not a joke. That's 6 months of hell that you would have spared a third of the women. So everybody in the US, my patients, they all get Oncotype DX. But the same token, you can have a very, very small tumor with no lymph node involvement, but then their recurrence score is like 60. I don't care if their tumor is half a centimeter, that patient gets chemotherapy because that's a very aggressive tumor. So the Oncotype DX is a very powerful tool in discriminating what is aggressive and needs chemotherapy and what is less aggressive and will only need pills, the AIs. Okay? Problem is, again, like anything else, it's pretty expensive. But if you are, I don't know how much it is. I think it's like 200,000. It's expensive, okay? But that's an option because think about it. How much is the chemotherapy gonna cost you? How much would it cost for the complications that are brought about by chemotherapy? You get neutropenic fever from the low blood count, you get hospitalized, antibiotics, hospital stay, and of course, the horrors of chemotherapy. You think about the cost of the test versus all this possible cost of, what's gonna happen if you do get chemotherapy, which you may not have needed to begin with. If you think about cost, so in the UK, the United Kingdom, where they have socialized medicine, and the UK is very particular in terms of what is cost effective or not. Which is why they don't use this drug Avastin in the UK, because they don't think 3 extra months, they don't think 3 extra months of life is worth the cost of Avastin. Ganun sila eh. But the UK system approved Oncotype. Because they figured if 1/3 of the patients are not going to need chemotherapy and you save 1/3 of the cost, it's cost effective. So just bear that in mind, Oncotype DX, okay? I gave a talk here once, but like I said, I don't know if people listen to me anyway. So that's the thing. Okay, now, in the metastatic ER/PR positive patients, okay? In the past, we would give them another Arimidex or another letrozole. We would switch things around. There's been a breakthrough, and it's a group of drugs called CDK4/6 inhibitors. What am I talking about? I don't think it's available here. I don't think it is because my fellows told me. Anyway, so there are drugs. One of them is a drug called palbociclib. Okay. Palbociclib. There's palbociclib. There's what is the name of that other drug? There are 3 of them. They're also pills, and they work in conjunction with an AI. All right. So if you combine Ibrance, palbociclib is Ibrance. That's the commercial name. I don't think it's available here. So Ibrance, you take it 1 pill a day for 21 days off the 4th week, and then you do the whole thing again. You take it with Femara. That is now the new standard of care in the US for metastatic ER/PR positive breast cancer. Yeah, Femara and CDK4/6, Femara and Ibrance. Okay. That is the latest thing when it comes to metastatic ER/PR positive patients. There's what is the name of the? There are 2 other formulations of that type of drug. I don't know if they're available here. But that's standard of care now in metastatic ER positive. Colon cancer, the thing about colon cancer is, for whatever reason, it's being diagnosed in very young patients. For the last 10 years, we see like 25-year-old patients with colon cancer. It's still a very curable form, especially if you find it early and you do the surgery, you do adjuvant chemotherapy, whatever. The latest thing about colon cancer is this, and it has something to do with what causes it. It's diet. Well, why is diet intimately associated with this? Well, because whatever toxin you ingest or create stays in your gut. Okay, and those bad substances cause mutations in the lining of your cells, and that's where colon cancer starts. All right. But here's the important thing. Just recently, about 3-4 weeks ago, right before we flew here. So a big topic or a big area of investigation in oncology now is what we call the gut, the intestinal tract microbiome. So all of us have bacteria in our gut. They're normally there for a reason. They make vitamin K. Okay, some of them are protective, so we have like a natural flora of bacteria in the gut, the good bacteria. When we eat tocino, the preservatives, and all this bad stuff, those good bacteria die. And so what emerges are the bad bacteria whose byproducts are toxins that are carcinogenic, that cause cancer. So that's a very active area of investigation now. There are oncologists who are looking at the makeup of the microbiome, and they've actually identified 2 bacteria which are bad. One of them is a fusobacterium, which is the one that they find in these young patients I was talking about with colon cancer. Another one, and I forgot the name of that bacteria now, is the one that they find in elderly patients who develop cancer. If you find those 2 bacteria, those patients are at risk for developing colon cancer. So be careful what you eat. All right? Filipino food, and I'm guilty when I come here, is really toxic. Oh my God. Eh, masarap eh. It's I'm not just talking cancer. My wife here, that's my wife by the way. She's a neurologist. It causes all sorts of bad things: cardiovascular, strokes, dementia, Alzheimer's, and then of course the cancer thing. So if you can change your diet, lifestyle, that's not just preventing cancer, but preventing other bad things. So my wife and I, when we come to the Philippines, we're like, bihira naman ito. Yeah. So, and okay, so preventative colon cancer, okay. Baby aspirin. I've said this before. Okay. One baby aspirin, 80 milligrams. Aspilet. Right here, aspilet. That decreases your risk of gastrointestinal malignancies by 30%. Okay? Just make sure, of course, but not the regular aspirin na matapang yan. Yung 80 milligrams. If you take that once a day, you decrease your risk by 30%. Just make sure when you take that, you take it with food. Kasi it will cause ulcers. Okay? It will upset your stomach. So that's proven. If your vitamin D, David, is low, you should take supplemental vitamin D as well. And people say, oh, don't worry, people in the Philippines, that's a sunny place. We will not have vitamin D deficiency. Oh yeah? Ilan mo nakita mo naglalabas sa labas na nakapayong? Ayaw natin umitim eh. You don't get vitamin D from the sun here. I bet you if you look at vitamin D levels of people here, a lot of them are going to be vitamin D deficient. And if you are, you should take supplemental vitamin D. Okay? There was a paper 2 years ago which was also presented in ASCO, and it's actually very interesting. And they looked at eating nuts. Not peanuts, nuts. 3 nuts. Cashew, almond, walnut. Hindi yung mani. Doesn't work. Kasi mani is a legume. It's in the root. The one that grows on trees. So kasoy. They actually also decrease the incidence of colon cancer. That's still being verified, but so what? Sarap yung kasoy eh. You just eat kasoy. Alright? This is also controversial is coffee. There was a study that came out of USC, University of Southern California, and it showed also that if you drink 3 cups, when I say cups, I'm talking about the mug, hindi yung tasa natin, the mug. You take 3 of that a day, you also decrease your risk of colon cancer. Now, here's the thing. It's not the caffeine. We don't know what it is in coffee. It's not the caffeine definitely. Because in that study, if you drink decaf, 3 cups a day, you get the same benefit. So if the caffeine, because they're like, well then I'll just drink Coke, caffeine, or tea. It doesn't work. There's something in coffee, we don't know what it is. And that's also the postulates. You notice if you drink coffee, you have a bowel movement. Maybe that's why. Coffee has anti-inflammatory effects, like vitamin B, and of course aspirin is anti-inflammatory. So what I do, I drink decaf. Same thing, you know. Any questions? I'll stop here.
So if someone has already had chemo, the oncotest will not necessary.
No. You do it on diagnosis.
Okay. And it's available here.
I think it is. I know there's a company here, because what happens is they actually fly your tissue to the US and they do the test there. The laboratory is in the US only. Or I think they're beginning to put one in Singapore as well. There are different companies that do the test. So there's Oncotype, you might heard of a test called MammaPrint. It's the same thing, it's a gene panel. However, Oncotype is the most studied. It is also the most verified. So if I were to do one of those genomic tests, Oncotype is what I'm going to do.
So if you have a recurrence, you have a chemo, and then you have a recurrence, oncotest is not.
No. Okay. One more thing I forgot, which is very important. Liquid biopsies. Who has heard of that term? Liquid biopsy. Okay, I gave a talk on that at Makati Med 2 years ago. All right. So here's the thing. So, how do cancer spread? You get into the bloodstream, right? So liquid biopsy is basically a blood test. So you take blood and then you look for tumor cells in the blood. Okay? But the problem is, if you do that, it's like looking for a needle in a haystack. Because you will not find intact cancer cells that readily. So instead of looking for the actual intact cancer cell, we look at the cancer cell DNA. And those can be identified. Not the cancer cell itself, just the DNA, because that's the important part. You can do that. Okay, so you do a blood extraction, about 10 cc, you send it to a place, a lab in the US.
Not here.
Huh?
Not here.
Not here. Not here. There are companies, I think, in Singapore and sometimes in China, who says they're doing the same liquid biopsy, but I kind of tend to trust what's already established. So it's a place called Guardant in the US. You do the blood test, you send the blood there, they look for the tumor gene signatures. the DNA of the tumors floating around. That you can find. All right? And then what do? You look for mutations for which you have drugs that you can use to target. All right? For instance, BRCA. For instance, PD-1, EGFR. They're actionable. You can find them in a blood test. So what is the applicability of this technology? Oh, lots. Okay, first of all, let's say you had a patient whose tumor came back. Okay, now, a lot of times, breast included, it's not going to be the same tumor you diagnosed years ago because these tumors mutate. Okay? So let's say you have a breast cancer patient, the lesion came back in the bone. You do a bone scan, bone mets, bone lesions, right? First of all, how are you going to biopsy a bone? Can't. It's painful. Not to mention the fact, I don't know how you're going to insert a needle in the bone. Okay? So if you do not have an accessible site to biopsy, how the heck are you going to know what that tumor is, number one, and what are the characteristics of the tumor? Because as I said, they can mutate. Then you do the liquid biopsy. Because those tumor signatures are floating around. You do the blood test, you send it for next generation sequencing, and you identify, oh, ito pala. Yeah, it's the same tumor as, 5 years ago. Oh, it's a different tumor now. Then you know what to do. Okay, that's number one. Number two, you had a patient who had a localized breast resection, lumpectomy. You gave the patient chemotherapy, high risk. And then how do you monitor whether the patient recurs or not? You do tumor markers, right? CA27, 29. And then you do periodic scans, right? Well, guess what? By the time something shows up on a scan, you're talking about 1 billion cells. They did studies in the US where instead of doing scans, they did serial liquid biopsies like every 3 months. If you find a rising tumor signature in the liquid biopsy, that patient will recur. By the time you see it in the scan, the liquid biopsy had already identified that 6 months earlier. So you can start the treatment earlier, and it's also more precise because you know the mutation.
Liquid biopsies.
Yes. Okay? Ask your doctors about that too, and ask them if it's available here. So you can predict who's going to recur or not earlier, much earlier than waiting for a scan. Okay? And then, of course, like I said, the treatment would be more precise because you know exactly what mutation you're dealing with. So instead of just giving that patient blanket chemotherapy, which may not be as effective, if you had a targeted treatment, then you not only get a better treatment for your patient, it's also less toxic. It's been validated. The studies are there. Matter of fact, I'm going to be giving that talk again with the updates on all these clinical studies that show how effective it is in monitoring patients in doing targeted therapy. So remember liquid biopsy. That is a very, 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 very hot topic in the US right now. Anything else?
Any other questions?
More.
One last. Tanong ko lang po kasi I was given a ribociclib although hindi ko pa na-start.
You were given what?
Ribociclib.
Oh yeah, then it's available here. The CDK4/6.
Which one?
Ribociclib.
Yeah, but the medicine was just given to me by my onco because it's very expensive. So it was given to me a dosage na is parang
That's for what cancer?
Breast.
cancer.
ER positive metastatic breast. Okay.
So binigay niya sa akin ribociclib.
Ribociclib is what is the commercial name of that in the US? It'll come to me in a while. Anyway, there's palbociclib, which is Ibrance. There's ribociclib, which is Kisqali. There you go. Huh?
Lapatinib.
No, that's different. That's oral tablet for HER2. We don't use that anymore.
No more?
No.
Seloda.
Yes, we do that.
You use Seloda.
Yeah, but that's for other things.
But not for her too?
No. No.
Not for her.
Absolutely not. Anyway,
As of now, I was given na parang three 3 doses na for every 21 days.
Correct.
So talagang ganun siya para
Yes.
sa chemo.
So, wait a minute. Bakit ka binigyan What is your disease metastatic?
Yeah, nag-lung meds ako
Okay.
sa 2 years ago.
Okay.
Tapos binigyan na ako ng
Piperacillin.
Yes. Tapos
That's
nawala naman siya.
Siloda. Ha?
Nawala naman
Okay,
siya.
good.
Gumaling siya. Tapos binigyan niya ako ng fulvestrant.
Yes.
Pero masyado siya expensive. Hindi ko kaya kasi injectable siya.
Yeah.
So, nag-stop ako for 3 months. Tapos ito yung binigay niya sa akin.
Now, your tumor is definitely ERPR positive.
Yes.
Because that will not work if it's not.
Yes.
Okay? Okay, good. I agree.
Tama yung, I'll trust my oncologist naman, ano. Tanong ko lang, bakit gano'n na 3 cycle, parang 3 gano'n yung, na parang chemo yung approach.
Because the studies show that that's the right dose. So you take it once a day for 21 days and then you're off the 4th week.
Once a day,
For
once
21
a day,
days.
how many tablets?
Isa.
Bakit sa akin parang, 3. Kasi
Tablets a
200,
day?
200 per tab.
That's supposed to be once a day. I-google mo yung Google mo yung dose
Ito
niya.
yung protocol ko eh. Tama.
Yeah, that's once a day. 600 milligrams is one tablet.
Okay.
Once a day. And like, ante ko na, see, he's giving that with what? So, yeah, fine, I agree.
Sabi nga, ito for 21 days.
Right, letrozole is in daily.
Daily na.
Stop, yeah.
Okay, thank you.
Sure.
What is the name?
Available lang pala siya rito. Good, okay.
Ribocycline.
Ribocycline is Kisqali. There's a third drug. I'll remember it. That's your other
Last question.
Kasi sa mahal, ba't hindi
Okay. All right. Thank you so much.
Thank you, Doc.
Thank you. Maybe September when I come back.
Yay!
We can request